Okay, here's today's quasi-literary CME code. Again, a couple of announcements. The end of year faculty meeting is August 7th. The location is going to be the same old place in the Bryant building. We've had a nice response of people who are going to attend in person. And the Durham Bulls game is still September 1. The theme of the faculty meeting is going to be the 10th year anniversary of the department, and house staff and fellows are invited. Will reminded me of this. We're moving next door to 2001 for a month. I think there was some mix up on this room, so don't worry about it. We'll all just move next door for a couple of weeks and then come back. Okay, so it's hot. So this is Phoenix. This was yesterday in the New York Times, 19 consecutive days with 110 degrees or higher. This forecast was updated this morning. The next 10 days are also going to be 110 or higher, which will be a total of almost a consecutive month with high temperatures over 110. I've never experienced that in my life, but they say it's a dry heat, so it's not too bad. This was in the New York Times too over the weekend. It's an actually, if you click on the link, it's a kind of a rolling show where you can look at how countries around the world are going to age. This is something related to Daniel's talk. This was 1990. This is currently, and you can look, Japan is already yellow, which means there are almost as many people over 65 as there are working people in Japan. And that just gets yellower. China makes that inflection around 2042. Europe is all yellow. Canada, our friends to the north, are all yellow. The US kind of hangs in there, but India kind of dominates everything because they're still going to have a very young population. But this growing aging of the population is going to be a real crisis for a lot of places. And I highly recommend this if you have access to it. A little bit on healthcare news. We don't have a case this morning, so I thought I'd go a little bit. You know, 15501 where the Wegmans is. So UNC is building a gigantic outpatient clinic facility there. If you've noticed the construction to the right, that was just approved. The idea behind that is to free up space on their main campus to build 1 or 2 new inpatient units. So, you know, they're right on our doorsteps there in Chapel Hill. Anyone want to try to pronounce this so I don't mess it up? No, I got to do it. So we'll put this as the Islamic New Year, Muharram. It's the first day of the Islamic New Year. In addition, the Rosetta Stone was found in this day in 1799. It's also the 191st anniversary of the founding of the British Medical Association. We have a couple of AllStars, Meg Sagita and Vincent Chang, and this is Tasneem, who nominated them. Her jaw dropped in amazement when she found that Meg and Vince had skillfully managed 17 consults in a single night shift while managing a seizing floor patient. I think that deserves a round of applause. More than just a coffee cup, that deserves a round of applause. So good for them. This is Rhino and Wayne nominating Michelle Marr and Andrea for recognizing a stroke patient who I know, who presented late at night with a weak hand and gave this patient TPA within 21 minutes, which has led to a significant improvement, and the patient is doing well. And thank you to both of you for doing that, and for Wayne too. Yeah. On the research roundup, Ornette and Kirby finally finished this and published the results of the model of TOM40 and ApoE. And Wayne was the lead author on a stroke editorial on the current knowledge base for TMS and post-stroke recovery. Also in the news, Ornette was talking about a new study using CRISPR gene editing for treatments for Alzheimer's disease. They kind of CRISPR your E4 into an E2. And Andy was on ABC 11 News about the FDA's recent approval of Lakembi for Alzheimer's, which Daniel's going to talk about. Why does Kyle love neurology? Kyle loves it, which I think a lot of us did because of the complete reliance on the detailed physical exam. I say the same, forget the history, just the diagnosis on the exam, and also grateful patients. And Kyle's a great doctor. Okay, this is a big weekend. It's the Barbie Oppenheimer. How many people are going to go see Barbie this weekend? Come on, admit it. What about Oppenheimer? Just 2? Oh my God. It's Christopher Nolan. I mean, he's like the Kyle Mitchell of directors. All right. This is today's CME code. And I'm thrilled to introduce Daniel. So Daniel, this is what he is. He's an assistant professor and a fellow. But Daniel is Durham's own. Daniel grew up in Durham. And it's not because his parents were professors at Duke. He's kind of like a working class hero and a super nice guy who works in the memory clinic. He went to Eastern Virginia Medical School, then got a degree at Duke and came back for his fellowship at Duke University. He studies the metabolomics, the biology of aging, exercise, calorie restriction, all of which he also practices, right? He's just a great doctor. And when I came here, I wanted to have a memory clinic that was composed of more than just a couple of neurologists. And now we have Kim from psychiatry, and we have 2 geriatricians, Heather Whitson and Daniel Parker, working for us. And I think the group as a whole functions much better than the sum of its individual parts. So I'm thrilled that Daniel's going to talk to us today about anti-amyloid therapy for Alzheimer's disease. So welcome, Daniel. Let me get rid of this. Which one? Go to share screen.
Can I do presenter view?
We got to share. Yeah, let me just get you out of this. Now you can take it away.
Thank you. No, I guess not.
What? Just go to the bottom.
There we go. All right, thank you for that introduction. So today I'm really excited to talk to you about anti-amyloid therapy for Alzheimer's disease, how we're using it at the Duke Memory Clinic. And I think it is opening and exciting a new chapter in Alzheimer's field. So no disclosures, just the outline of what I'm going to talk about today. So first, I'm just going to start with a little bit of background and history about anti-amyloid immunotherapy for Alzheimer's disease, give you kind of an overview. These drugs have been in development for around 2 decades now, and we finally have a couple candidates that seem to make a difference. And then I'm going to talk about efficacy with a focus on lecanumab. So that's the one that has been fully FDA approved and the one that we're currently using in clinic. I'm going to talk about adverse effects and the monitoring we do for that. And then who's an appropriate candidate for lecanumab treatment and what some of the open questions and next steps in the field are. So you're going to hear me talk about 3 drugs and 3 sets of studies in this talk today. So the first anti-amyloid immunotherapy that was approved by the FDA under the accelerated approval pathway was aducanumab, and that happened back in June of 2021. and that was based on findings from the eMERGE and ENGAGE trials. The next one that came out was lecanumab, and the phase 3 trial that documented efficacy of lecanumab was called Clarity AD. And then finally, the third drug that is not yet FDA approved, but we anticipate will be FDA approved probably within the next year or so, is called DanaMap. And the family of trials that were used to justify its approval or demonstrate its efficacy are called the Trailblazer-ALZ trials. So I will be referring to these throughout the talk, and hopefully I can help keep them straight. So just a little bit of timeline of anti-amyloid monoclonal antibody therapy. So the first anti-amyloid monoclonal antibody was actually given to patients back in 2007. It was called bepanumab, and safe, just didn't do a great job of reducing amyloid. It stopped the accumulation of amyloid, but it didn't get rid of the amyloid that was already there. And so it took a while to identify a set of candidates that were actually effective at removing amyloid. And the first of these was aducanumab. And it began its phase 2 testing back in 2012 with the PRIME studies. And then in the fall of 2015, Biogen launched the phase 3 ENGAGE and eMERGE trials of aducanumab, which were designed to test its efficacy. However, in March of 2019, Biogen terminated these 2 trials after they did an interim analysis that demonstrated futility. But we were all shocked, and about 6 months later, when they published a revised analysis of participants in the aducanumab trials who received the highest dose of the drug for the longest period of time. And they claimed that in that analysis, there was actually a signal demonstrating some efficacy with their primary outcome, which was slow and cognitive decline. And so in July of following year in 2020, Biogen then requested FDA approval for aducanumab. The FDA Scientific Advisory Committee, which the FDA typically listens to, voted almost unanimously against approval for aducanumab. However, the FDA ignored their advice, and in June of 2021, they approved it under their accelerated approval pathway. Several of the members of that Scientific Advisory Committee resigned in protest. There were concerns that there were improper communications between Biogen and the FDA. There was investigation by the FDA as well as Congress. I don't think any, grand conspiracy theory was identified, but I think it kind of, tarnished the field a little bit, and perhaps, increased skepticism about this family of drugs. Around that same time, CMS also began developing a coverage policy for these drugs, and that was completed in April of 2022. And as part of that coverage policy, they said they would only cover anti-amyloid monoclonal antibody therapy for patients or patients who are enrolled in a clinical trial or registry study, and that policy remains in effect. And because of the slow uptake of aducanumab, the skepticism around its efficacy, which I'll talk about a little bit later, there wasn't a lot of excitement or interest in the drug. There weren't a lot of patients who were treated with it. And as far as I can tell, I think Biogen has basically kind of abandoned it in favor of lecanumab. So the story of lecanumab really starts to get interesting in 2017 when Eli Lilly launched the phase 2 trials. When Eisai launched the Clarity AD trial for lecanumab, and the results of that were announced in 2022, and showing some efficacy with that. And then in January of this year, FDA granted accelerated approval to lecanumab, and then we started treating patients with it in May of this year at the Duke Memory Clinic, patients who could pay out of pocket for it as it wasn't yet covered by Medicare. And then just Monday, they announced the phase 3 results from Trailblazer-ALZ 2 and published the results in New England Journal of Medicine showing, that was DanaMap. I'm sorry, I'm getting confused here. And then lecanumab was granted full approval in July. DanaMap has also followed kind of a similar timeline based on the Trailblazer-ALZ studies, and the results of Trailblazer-ALZ 2, which was the phase 3 study of DanaMap, was announced on Monday, published in New England Journal of Medicine, and also showed efficacy. So there's been a lot of work done over the past 2 decades to evaluate these drugs and to get them through the clinical trials. And now we have 3 drug candidates that are either partially approved, fully approved, or will be approved for use in Alzheimer's disease. So how do these drugs work? So just a little bit of background on Alzheimer's disease and the kind of theory about why Alzheimer's disease develops. It's called the amyloid cascade hypothesis. And it basically positions Alzheimer's disease as an amyloid-mediated tauopathy. And so it begins with amyloid beta. So this is a protein that's produced in the brain and other parts of the body. Its function isn't exactly fully understood. It seems like it's important for synaptic function, may also be part of the brain's innate immune system. But people who have increased production of amyloid because of mutations on the amyloid precursor protein or in the presenilin genes, which are important for amyloid processing, are at increased risk of Alzheimer's disease. And that's the basis for familial Alzheimer's disease, where Alzheimer's disease develops in younger patients, typically in their 50s. And then we also know that people who are carriers of the ApoE gene have an increased risk of developing late onset Alzheimer's disease. So that's Alzheimer's disease that develops after age 65. So, and they accumulate amyloid at an earlier age and at a faster rate compared to people who are not carriers of the ApoE4 allele. So as people develop amyloid, accumulation amyloid plaques in their brain, in some individuals, this leads to the development of tau pathology. So tau is a microtubule-associated protein important for the brain scaffolding. In susceptible individuals, once you reach a certain threshold of amyloid, that triggers the accumulation of tau tangles. And then those tau tangles are toxic to neurons, lead to neurodegenerative changes in the brain. Typically, these begin in the medial temporal structures, leading to short-term memory impairment, and symptomatic cognitive changes, which then manifest as mild cognitive impairment, meaning there are changes in memory and thinking that are apparent but aren't interfering with day-to-day function. And then as it progresses to affect those day-to-day activities, we call that dementia. And so the way these anti-amyloid monoclonal antibodies work is by disrupting the formation of amyloid plaques, clearing those plaques from the brain. They trigger an immune response leading to microglial activation and removal of plaque, with the idea being if we can get rid of the plaque, then that can decrease the formation of tau pathology, and that can stop this cascade and potentially even give the brain an opportunity to heal and maintain its cognitive function. So amyloid biology is very complex. So amyloid beta protein exists as a monomer, but it can oligomerize and then form fibrils. And then those fibrils can aggregate into insoluble amyloid plaques, which are part of the neuropathological basis of Alzheimer's disease. And each of the monoclonal antibodies that have been tested have targeted a different form of amyloid. So some of the earlier ones, crenezumab and solanezumab, targeted the monomer. Lecanumab and aducanumab target the oligomers and fibrils. Bapineuzumab targeted fibrils, and then DanaMap and gantenerumab target the amyloid plaque. And so the 3 drugs that we have that have demonstrated some efficacy clinically are lecanemab, aducanumab, and DanaMap. And why these and not the others? So most likely because the other ones just didn't get rid of amyloid effectively. So some of them were able to stop accumulation of additional amyloid in the brain. Others were able to remove some amyloid. But lecanemab, aducanumab, and DanaMap seem to be the most powerful in terms of getting amyloid out of the brain. And there's evidence that to really see a clinical benefit, you need to get rid of most, if not all, of the amyloid that's present in the brain. So it's not surprising that these other drugs failed since they didn't actually get rid of amyloid. So now I want to talk about lecanemab. This is the one that we're using in the memory clinic. And this is the one that has been fully approved by the FDA as of July 6th of this year. And that approval was based on the results of the phase 3 Clarity AD trial. And so this was a trial that included about 1,700 participants. These people were people who had mild cognitive impairment, meaning they had apparent cognitive changes, but those changes didn't have any functional impact, or they had very mild dementia due to AD. So that means that maybe they had some difficulty managing medications or paying their bills, but they were otherwise independent. So very mildly symptomatic patients. The study enrolled people between 50 and 90. It was pretty permissive with respect to comorbidities. So it had a nice kind of representation of the population as a whole, at least with respect to comorbidities. All of the participants in the study had confirmed Alzheimer's disease. And so that was done based on CSF testing or amyloid PET imaging. And that was, a bit of a difference because in the past, earlier in the 2000s and the 90s, many of the, when clinical trials enrolled patients for different interventions against Alzheimer's disease, oftentimes that diagnosis was made clinically. There wasn't biomarker testing available. And so we know that in these early trials, up to 25% of participants actually didn't have Alzheimer's disease. They had something else. And so that was, one of the strengths of having the PET ligand and then the CSF testing. We're actually able to confirm that people have Alzheimer's disease before enrolling them in the study. There were exclusions based on MRI findings, which I'll talk about a little bit later, unstable medical conditions, depression, stroke, history of CVA, bleeding disorders or seizures. If people were taking donepezil or memantine, these are the symptomatic treatments that we use for Alzheimer's disease, that was totally fine. And you can see that the average age of the study participants was early 70s. Most of these participants had had symptoms for several years. And you can see that the majority of them were in that mild cognitive impairment category. So very mild symptoms. And then about 40% were in the mild Alzheimer's disease dementia category. And most of them had at least one copy of the ApoE genotype, and about half of them were using one of the symptomatic treatments for dementia. One of the, I think, major limitations of these family of trials for all of the drugs was just the lack of recruitment of African-American or Black participants in the studies. So in the Clarity AD trial, which was the phase 3 trial for lecanumab, as well as the Trailblazer ALLS 2 trial, which was the phase 2 trial for DanaMap, Black participants made up about 2% of the study population. And in Emerge and Engage, which were the 2 phase 3 trials testing aducanumab, there weren't any Black participants. They were all either white or Asian. And so we know that in this country, African Americans are at an increased risk of developing dementia. There's also differential effects of the ApoE genotype on dementia risk in African Americans. So I think it would have been really nice to have more representative samples. So that's one of the major limitations of this family of studies. So we know that these drugs do a really good job of getting rid of amyloid. So the figure here on the left, you can see a representation of the amyloid PET scan, and the red areas are where the ligand is binding to the amyloid plaques in the brain. And you can see in the top image that there's a lot of amyloid plaques. And then after treatment, most of that amyloid is gone. And so we know that lecanumab and DanaMap are very effective and very quick at reducing amyloid in the brain. You can see that here on the figure. So this is the PET SUVR, which is a measure of the amyloid burden in the brain, and that's on the y-axis. And you can see that as it's getting lower, that's reflecting a reduction in the amyloid burden in the brain. And you can see in the placebo group, which is the line in blue, that over the 18-month course of the study, there's a gradual increase in the amyloid burden, increases by about 4 centiloids per year. Whereas in the treatment group, you see a very quick and drastic reduction in amyloid. And that was seen, a statistically significant difference in amyloid burden was seen as early as 3 months with treatment with lecanemab. So very effective at reducing amyloid. But the question is, does that translate to a clinical benefit? That's what we care about. And so the primary outcome measure for the Clarity AD trial of lecanemab was the clinical dementia rating sum of boxes. And so I'll go into some of the details of this assessment instrument shortly. And you can see here that on the y-axis is adjusted mean change from baseline. And so the way this scale works, as the number increases and it goes from 0 to 18, you see that reflects greater disability, greater cognitive impairment. And you can see here that participants who were randomized to receive lecanumab had about a 30% reduction in decline in their cognitive performance as measured by this assessment instrument over the 18-month period, whereas the placebo group had a bit of a steeper decline in their cognitive performance. These were some of the other pre-specified secondary outcomes from the Clarity AD trial, again, looking at lecanumab. And these measures are all very similar. They look at different areas of cognitive function as well as functional status. And you can see that lecanumab met all of these pre-specified secondary outcomes as well. There was a similar reduction in decline using all these measures, and that was commensurate with the clinical dementia rating sum of boxes, which was the primary outcome measure. And so based on a modeling study that was done, it was estimated that lecanumab slowed the progression of Alzheimer's disease from that either mild cognitive impairment stage or early mild dementia stage to the more moderate and severe stages. And it also reduced the time spent in these more advanced stages. And it was estimated that treatment with lecanumab in this patient population would lead to an increase of about 3/4 of a quality adjusted life year, delay the time to progression to dementia by about 3 years, reduce institutional care by about 1/10 of a year, and increase the time in the community by about a year, which I think are outcomes that most patients living with Alzheimer's disease would value. And there were also improved health outcomes with lecanumab. And there was evidence that the earlier in the disease process treatment was started, the lesser amount of tau pathology they had, that they were more likely to benefit with a greater gain in quality adjusted life years compared to those who were further along in the process in the mild AD dementia subset. So this is the clinical dementia rating instrument. This was the primary outcome measure for the Clarity AD trial, as well as the Emerge and Engage trials of aducanumab. And this was a secondary outcome measure in the Trailblazer-ALZ trial of DanaMap. And one of the major criticisms of lecanumab and this drug class in general has been that the clinical benefit seen using this measure is pretty small. And that's been a major question about whether it's worth it, given the risk and the logistical the time commitment required for treatment with this drug. So this instrument looks at 3 different cognitive domains: memory, orientation, judgment, problem solving, as well as 3 functional domains: so functioning in community affairs, home and hobbies, and personal care. And this was designed to reflect domains of both cognitive and function that are important for patients and their loved ones. And so the way this is scored, it's scored from 0 to 3, 0 being no impairment, 0.5 being questionable impairment, and then 1 through 3 reflecting mild, moderate, and severe impairment. And then you sum the score for each of the domains, and that gives you the sum of boxes score. So the range is from 0 to 18. And so the way we use this for staging, so 0 is normal, 0.5 to 4 is questionable cognitive impairment, 4.5 to 9, mild dementia, and then moderate and severe dementia. And a meaningful clinical difference is defined as 1 point change in the CDR sum of boxes. So if we look at the results of the study, the Clarity AD trial, looking at lecanumab at baseline, participants in both groups had a CDR sum of boxes of around 3. So that could be questionable impairment in 4 of the domains, no impairment in 1, and mild impairment in another. So very minimal impairment at baseline in both of these groups. And then over the course of the 18-month study period in the placebo group, you see a worsening of about 1.7 points on the CDR sum of boxes. So not a huge change over the 18-month time period, even in the placebo group. And then if you look at the treatment group compared to the placebo group, there was about a 1.2 point worsening in their performance, in their kind of global performance based on this measure. So if a clinically meaningful difference is defined as 1 point, and the placebo group only declined by about 1.5 points, then that would require really powerful drug effect to be able to measure that in the 18-month time period of the trial. And I think there's some biological reasons why expecting such a big difference so quickly isn't really plausible. And so, I think this still reflects a meaningful difference with the drug treatment. And then looking at the Trailblazer-ALZ 2 trial, which was phase 3 trial of DanaMap, at baseline, participants were slightly more impaired with a CDR that averaged around 4. And then you saw a similar decline in the placebo group, slightly worse, but a similar benefit with treatment to lecanumab. So we have 3 drugs. They all have a similar efficacy based on CDR sum of boxes. So I think, most likely the effect is real. There were some questions about, could this be potentially confounded by unblinding? So these drugs are associated with infusion reactions, happens in about 25% of participants with lecanumab. And then if they developed any of the side effects, that could have led to unblinding, which could have influenced, participant and their caregiver reports of, their functional status if they were able to figure out that they were receiving active drug. But I think overall the evidence points to a real and meaningful treatment effect with these medications. So this is from, I'm sorry. Sure.
The main difference between based more than MCFD. It's very interesting, in stroke, there was this the other trial. How did stroke work? And so how does the AD the difference between very small?
Yeah. So I'll talk a little bit about why I think that occurred as we move on. Okay. So these are the data from Emerge Engage. So these were the phase 3 trials of aducanumab. So this was the first drug in this family that was approved back in June of 2021. This study had different dosing groups. And these studies also changed the dosing regimen partway through the study. And so there were some issues, with the study design that I think undermined, interpretation of the results, as well as the fact that Biogen terminated studies halfway through based on that interim futility analysis. And so in the Engage group, there wasn't a significant difference between the treatment and placebo groups, but in the Emerge trial, there was, and it was a similar effect size to lecanumab and donanemab compared to aducanumab. And then the same thing for the donanemab. So with the donanemab study, what they did was they divided the participants into 2 groups based on how much tau burden they had, with the idea being that the more disease you have in the brain, the further advanced the disease is, the less likely that you're going to benefit from amyloid removal because you already have a substantial tau burden, you already have substantial neurodegenerative changes. So, presumably removing amyloid is going to have less of a benefit. And so they did see, a slight difference between the 2 groups. But again, the effect size was similar in the donanemab study, about a 30% reduction of decline compared to placebo, as the lecanemab Clarity AD and the aducanumab Emerge Engage studies. And 47% of participants receiving donanemab had no change in their cognitive performance as assessed by the CDR at 1 year compared to 30% who received placebo. So less likely to progress on DanaMap compared to placebo. So is there a sustained benefit over time to amyloid reduction? So these trials lasted 18 months. We know that for lecanumab, about 2/3 of patients were amyloid negative by the conclusion of the trial. There's evidence that you don't start to see a real substantial clinical benefit until you achieve almost complete amyloid removal. So it could be that the 18 months of the trial just isn't long enough to get rid of all the amyloid, give the brain some time to recover, and then to show a real benefit on the downstream phenotype of cognitive performance, which is what we care about. And so these are data from open label extension of aducanumab treatment. And you can see on the left in this blue box, this is the placebo-controlled period. So this is the actual trial period. And then after that, all participants were receiving aducanumab. And I just want to point your attention to the high dose groups, which are down here in this kind of dark purple color. And this is the 10 milligrams per kilogram group. This is the highest dose group. And you can see here that over the course of this open label extension period, where all participants received aducanumab, they were able to reduce their amyloid burden and maintain a low amyloid burden in this group. On the x-axis is the change from baseline in the PET amyloid imaging. And then here on the right, this is the CDR sum of boxes. And this is change over time for this 4-year study period. And you can see here again in the high dose groups, they had the lowest change in their CDR over the course of the study compared to the lower dose groups. So it seems like more effective amyloid reduction over a longer period of time translates to an accumulating benefit in terms of maintenance of cognitive function. This is limited data that was produced by the pharmaceutical company, so we have to take it with a grain of salt. There's also been some data from the DanaMap open label extension, which had a small number of participants, but it also showed a similar sustained benefit. So there is some evidence that the benefit is maintained over time as long as the amyloid remains low, and that you see stabilization of cognitive decline based on these limited data, which I think is hopeful. So this had, so there were about less than 100. Yeah, so probably about 60 total. So not a lot. So this is a cartoon model that kind of outlines the hypothesis I was just kind of describing. The red line is reflecting amyloid PET, plasma p-tau, which is another marker of Alzheimer's disease pathology. And the gray box reflects the amyloid depletion phase. So this is the clinical trial period, 18 months. So during that time, you have reduction of amyloid. And over the course of the trial, most participants are able to achieve enough reduction of amyloid that their amyloid PET is negative. It looks like someone without Alzheimer's disease. And so Robert Nitsch, who produced this model, hypothesized that you have a period of amyloid reduction. And then that's once you reach a certain threshold of amyloid reduction, where the vast majority of the amyloid is gone, you have reduced neurotoxicity. And then as that neurotoxicity and the inflammatory response and all the other responses to the amyloid pathology kind of wind down, you have a stabilization phase. And so it could be that 18 months just wasn't a long enough time to really capture the full benefit of this treatment. And I think that makes sense when you think about the timeline of the pathogenesis of this disease. It develops over decades, and there's typically substantial neurodegenerative changes by the time people manifest symptoms. So it could be that treating participants or patients in these early symptomatic phases is already too late. And this hypothesis is also being tested in several trials that are ongoing. The AHEAD trial and Trailblazer All 3, which are looking at using these drugs in people who are cognitively normal, but have evidence of increased amyloid accumulation to see if it can prevent the development of cognitive changes. And so those trials are currently underway. Duke is the site for one of the trials, and expect results in that, I believe, sometime late next year. So what are the side effects of this class of medications? So with lecanumab, at least the most common side effect is an infusion reaction that occurs during or shortly after the infusion that happens about 25% of people, typically mild, easily managed with things like Tylenol and Benadryl. The side effect that we really worry about that is potentially life-threatening is called ARIA, and that stands for amyloid-related imaging abnormality. And there are two flavors of ARIA. There's ARIA-E, which refers to edema or swelling in the brain, and then ARIA-H, which refers to hemorrhage, microhemorrhage, or bleeding in the brain. And so this is a class effect for this family of medications. And I'll go into the incidence and the differences between the drugs shortly. Most cases of ARIA, though, are asymptomatic. It's just picked up on the routine MRI monitoring that's done as part of treatment. However, there can be symptoms related to ARIA, and these include things like headache, confusion, visual changes, dizziness, nausea, gait, and difficulty. And then rarely you can have serious ARIA or severe ARIA, and that can include things like seizures, encephalopathy, stupor, focal neurological deficits, and there have been deaths directly related to ARIA. So with lecanumab, there have been 3 deaths in these patients. From what I've been able to gather from the information that's available, these were all people who were receiving a blood thinner, or in one case, this person was having a stroke and received TPA, subsequently developed brain bleeding, and then died. In the Trailblazer-Alls study that was just published in JAMA on Monday, there were 3 deaths with DanaMap due to severe ARIA that was unrelated to anticoagulants. And there have also been several deaths reported, at least 5 from what I've seen, with aducanumab potentially related to ARIA as well. So it's similar to Clarity AD, is about 1,800. Yeah. So incidence of ARIA for the 3 drugs. So aducanumab appears to have the highest incidence of both ARIA-E at least, whereas DanaMap appears to have the highest incidence of ARIA-H. We know that this risk is increased in people who are carriers of the ApoE4 allele, which is why we are genotyping our patients before treatment. And actually, the VA has said, given the increased risk of ARIA in people who are E4 homozygotes, that they're not going to be eligible for treatment at the VA if you're an E4 homozygote. But it appears, based on the currently published data, that lecanumab is the safest, has the lowest incidence of ARIA-E, so about 13% of participants total. And E4 carriers is about 11% compared to 5% non-carriers, but still substantially higher in people who are E4 homozygotes. Similar pattern with the bleeding. If you have 1 copy of E4, increased risk. If you have 2 copies, substantially increased risk. And so here is another breakdown of the incidence of side effects. Just want to point out that while this happens in about 13% of participants, that in the vast majority of cases, it's asymptomatic. So looking at all participants, only about 3% of participants in Clarity AD looking at lecanumab developed symptomatic ARIA. And so, most of the time, this is just picked up on the routine MRI monitoring that's done as part of treatment. And so what do we do if we find ARIA? So if patients have symptoms, we tell them they have to call us immediately, let us know, and we get an MRI as soon as possible. And then there's 2 ways that we look at ARIA. One, whether or not it's symptomatic, and then based on radiographic features, it's classified into mild, moderate, or severe. And so here's the rubric for doing that. I won't read all of this. You can see that it's based on, the size of the edema, the number of microhemorrhages, and then if there are any areas of superficial siderosis. And then based on this classification, we make a treatment decision. So if someone has symptoms, the treatment is held until symptoms resolve and there's improvement of the ARIA, resolution of the ARIA on MRI. We do routine MRIs throughout treatment to monitor for ARIA. So sometimes we may pick this up in patients who are not having symptoms. So if it's asymptomatic and it's mild based on the radiographic criteria for ARIA-E, then we're able to continue treatment. If it's moderate based on radiographic criteria, we suspend dosing, repeat the MRI every month until we see resolution. And then based on discussion with the patient and our clinical decision-making, we can make a decision whether or not to resume treatment or stop treatment. And if it's severe, again, look at that and make a decision about whether or not we want to continue. And it's a similar approach if it's the ARIA-H. So this is the way kind of the treatment protocol works. So we do our eligibility assessment at the memory clinic, evaluate patients and diagnose them. And if they are in that mild cognitive impairment category or that mild AD dementia category, then they're eligible for treatment with lecanumab. They have to have evidence of Alzheimer's disease, and the way we're doing that in clinic is using lumbar puncture. They have to have a baseline MRI within the past year to look for any exclusionary factors, which I'll go over shortly. And then we also do ApoE genotyping to better get a sense of their risk of ARIA so that we can counsel them better. There's no dose titration required for lecanumab. That's in contrast to aducanumab, where there was a dose titration. And we do monitor for that infusion reaction after the treatment. And typically infusion reaction happens the first couple of times patients receive the infusion, gets better. So we observe them, longer during the early infusions and then less frequently thereafter. It's given every 2 weeks. So it is a substantial time commitment for patients. And right now we're just infusing at the Clinic 2A at Duke Hospital. And we do have several patients who are driving hours to come to Duke for this treatment. And then we do MRIs prior to the 5th infusion, 7th infusion, and then the 14th infusion to evaluate for evidence of ARIA. If ARIA is going to happen, most likely it's going to happen in the first 6 months. And so that's why we do those 2 monitoring MRIs early in the process. This is from Andy Liu, who's developed a management protocol for severe ARIA management. So this is for patients who are having severe symptoms related to ARIA, which can include things like seizure, stupor, encephalopathy, focal neurologic changes. And so the treatment for that is steroids, IV steroids to start, followed by oral steroid taper, seizure management with benzodiazepines, anti-epileptic drugs if indicated. And so that's our protocol should patients need inpatient management for ARIA symptoms. There's also been an interesting finding related to changes in brain volume with this family of drugs. So this is from a systematic review and meta-analysis looking at whole brain volume changes with anti-amyloid therapy. And you can see that compared to the other anti-amyloid monoclonal antibodies, DanaMap and lecanumab are both associated with a significant reduction in whole brain volume. There's been a concern that this is atrophy reflecting neuronal cell loss. I think it's a little bit earlier to reach that conclusion. There is some evidence that people who have amyloid buildup in the brain but don't yet have significant neurodegenerative changes have a larger brain volume, perhaps related to that amyloid accumulation, maybe some kind of inflammatory response. And so as these drugs are rapidly removing amyloid from the brain and that response resolves, this may actually reflect their real brain volume without the amyloid. I think it's a little reassuring that we didn't see loss of hippocampal volume with these drugs. There's not really been evidence that they affect hippocampal volume. So I think that, supports the idea that this is a treatment effect and not related to increasing atrophy in the brain. And there was also a trial, the SPRINT-MIND trial, which looked at intensive blood pressure control to reduce the risk of developing dementia, which showed that intensive blood pressure control did reduce that risk. And they also found reductions in brain volume with intensive blood pressure control. So I wonder if it's, perhaps a treatment effect that's reflecting the beneficial effects of the drug rather than increasing atrophy in the brain. So who's eligible for lecanumab? So these are from the appropriate use recommendations, which were published earlier this year. So you have to have mild cognitive impairment or mild dementia. You have to have evidence of Alzheimer's disease. So either amyloid PET or CSF studies showing Alzheimer's disease. You have to have cognitive performance testing that shows mild impairment. So that could be an MMSE of 22 to 30, a MoCA greater than 16. And that's, to demonstrate consistency with the diagnosis of mild cognitive impairment or mild dementia. Symptomatic treatments like donepezil, ribostigmine, memantine are okay. And then the patient has to have adequate family support, and they have to have a good understanding of what this involves. It's every other month or twice monthly infusions, several hours, significant risk of side effects. So the patient has to be attuned to that, have to be willing to watch out for that and let us know. And the exclusionary criteria, so there can't be anything else that's causing the cognitive changes. So, some other pathologic process that's not Alzheimer's disease or severe depression. They have to be able to have an MRI. So people who have pacemakers or other devices that are not MRI compatible, cannot receive lecanumab. If they've had a stroke or TIA within the past 12 months, that's contraindication, any history of seizure, psychiatric illness. If they're receiving some kind of immunologic treatment, so another monoclonal antibody, immunosuppressant treatment for rheumatoid arthritis, then they're not eligible. If they're at risk of bleeding or have other medical problems that could affect or be affected by lecanumab. And then if they have evidence on MRI of things that could potentially increase their risk of bleeding or ARIA, then that's also exclusionary criteria as well. So to summarize, we now have 3 anti-amyloid drugs, aducanumab, donanemab, lecanumab, that have either been fully approved by the FDA, so that's lecanumab, approved under the accelerated pathway, which is aducanumab, or we expect to be approved within the next year, that's donanemab. They all have similar, modest, perhaps marginal efficacy. There is some evidence that may increase over time with longer durations of therapy, but we don't know that yet. And so, this could turn out to be another disappointment, as many people in this field are familiar with. And then also, a lot of the studies didn't recruit adequate numbers of African-American patients. We know that they're at increased risk of Alzheimer's disease, that ApoE exerts differential effects on their risk. So, it would have been really helpful to have representation in the studies, so we can't generalize fully to our African-American patients. Of the 3 drugs, lecanumab does appear to be the safest with respect to ARIA based on the data that we currently have available. As part of the approval process, all patients who are receiving this drug under Medicare coverage, we have to enter their information into a registry, so we will be monitoring for side effects, and hopefully we'll have a better sense of real-world risk data. And then we still have to figure out the duration of therapy. Do we continue people on therapy for life? Do we do intensive therapy for 18 months and then switch to maintenance dosing? That's probably how this will turn out, but unsure at this time. Is there accumulating benefit over time? There's some evidence for that, but it's really unclear based on the data that's currently available. So in terms of next steps, we got to figure out optimum duration of therapy. I think some good news is that Eisai is working on a subcutaneous version of lecanumab that can be administered at home. And they expect to have this available sometime early next year. And so that would greatly alleviate some of the logistical burden that patients face when receiving treatment with this drug. We're also evaluating these drugs as prevention. So people who are at increased risk of Alzheimer's disease, who have evidence of amyloid accumulation, but are not yet symptomatic, cognitively normal, to see if treatment with this medication can prevent the development of cognitive symptoms. And then I think another important thing is going to be to look at combination therapy. Can we get a better response if we combine lecanumab with an anti-tau agent, or lecanumab plus an immune modulator, or other therapies? And there's still no disease-modifying therapies currently available for other causes of dementia, like Lewy body disease or FTD. So still a lot of work to do to figure out the best way to use this drug, the best population to use it. But I think, it's our foot in the door for something that can make a difference for our patients. And I'll open it up to questions.
This doesn't work.
Okay.
Did it load from there?
It did, but it's the old version. So I could download it.
Okay, so stunned silence. Let me ask the two obvious questions. So first of all, you said anticoagulation is an exclusion. Is that really true?
Yes, it's not listed on the label as an exclusion. It was included in the appropriate use recommendations as an exclusion
You mean by a panel of experts?
by a
Not
panel
the
of
FDA.
experts, not the FDA. So in the prescribing information, it's recommended that you have a discussion with patients if they're on an anticoagulant, and if they understand the risk benefit and are willing to proceed, then you can move forward. I would be very reluctant if someone is an ApoE4 homozygote on anticoagulation to treat with this medication. But this is a life-limiting disease that robs people of their
Then you get that
identity.
Gizmo installed.
Oh yeah, you can get the Watchman device, get off your anticoagulation, then get Lacana MAP. So may have some patients who want to do that, but
Okay, and the second thing, I mean, the stroke doctors all raise their hand. They want to know about TPA.
yeah.
Because these are old folks and they're going to have strokes.
So.
Wait a minute, you'll be next. Yeah.
I
So
mean-
if I'm having a stroke.
Yeah.
And I'm on lecanumab, I want the TPA. Save me or kill me.
Yeah, I mean, I agree. I would want the TPA.
Yes, so we're not having for the treatment.
Yes, you are.
You're not.
Oh, no. If I'm on lecanumab and I
Yeah.
have a stroke.
Yeah.
Then I
You
want
exclude
TPA.
those patients, they are at a high risk of stroke.
Right, but let's say they're all gonna be 80 years old. They're all gonna be having strokes.
No, 80 you stand, they all have it, they're not gonna get medicine. You're really for the staff.
Agreed, but people will have their first stroke
Yeah,
while.
three microbeads. Yeah,
But they'll
so
have their
those-
first stroke.
Yeah, that's-
Because they-
they're not gonna get it.
All right, let's say I've been on lecanumab for a year, kind of stabilizing, not as disinhibited, and then I come in with a big old stroke. You better give me TPA.
Yeah, I mean, I agree. I think if you look at the risk benefit, the risk of disability, permanent disability related to the stroke, I don't think you can exclude someone from getting TPA based on the N of one, patient who was on lecanumab got TPA and had a bad outcome, because, patients who are not on lecanumab who get TPA sometimes have bad outcomes.
And you're
So,
gonna know from all their MRIs whether they have microhemorrhages or not,
Yeah.
right?
Potentially. So it depends on when they have the stroke. Potentially.
No, I agree, but they've had 3 MRIs that show
Yeah,
you they
I
don't have a
agree.
history of microhemorrhages. Yeah. So give me the TPA, don't hold it.
Yeah.
I mean, that was Ryan's talk, people with disabilities getting TPA and stuff. So that will be us. Lecanumab people will be disability people.
Yeah.
Okay, Ryan and Wayne.
They define, so the sum of boxes score, clinically meaningful difference in one, they define that throughout the scale, because in theory, it's a non-linear change, right? So the lower the scale, like the more clinically, or the difference between a 3 and 3.5, may be more clinically meaningful than a 16 to a 17 or a 10 to 11. So they treat that all linear, or they look, that could be like the argument for why the scale change may be low, but they actually.
yeah. I mean, I think that's a great question. I'm not familiar with enough of the performance characteristics of the scale to know, I mean, the scale was designed for evaluating disease modifying therapy in Alzheimer's disease. So I would presume it, has a, linear kind of progression throughout the scale, but I'm not sure. Yeah.
Wayne?
So CMS covered the drug.
CMS, yep. So as of July 6th, they're covering the drug for participants who are enrolled in the CMS registry.
So I just wanted to.
But so far, like commercial Blue Cross hasn't said it.
Yeah. And we don't know about Medicare Advantage.
Very similar pictures. The MCIP is on that, but the approval, CMS and Neurology covered, and all the private insurance have covered. The device approved for 3 years, and then by 30 just.
Yeah, there's gonna be a lot of people who want this.
Yeah.
I think the treatment of asymptomatic people could be a game changer.
Yeah.
The question is then, I mean, I was around when HIV treatment first came out. And before that, nobody wanted to check whether they were, whether they had HIV or not, because there was no therapy. So does this mean people should run out and check their ApoE status if they're my age, for instance, and they have a family history, and then sign up for the AHEAD study?
I mean, I think, if we're using these drugs in 10 years, I think probably, and let's say, the AHEAD study pans out, the Trailblazer ALS-3 study pans out, these prevention studies, it probably looks something like colorectal screening. You'll go in to your PCP, they'll do a blood test, which is kind of like a screener to see if you have evidence of amyloid buildup in the brain. If you have if that blood test is positive, you undergo definitive testing with either lumbar puncture or amyloid PET. If that shows evidence of amyloid accumulation, we'll start you on one of these drugs with the goal of preventing the onset of cognitive impairment. So I think that's the direction the field's moving in. It's easier to prevent damage than to repair it. So that's my guess for how we might be using these drugs in 10 years.
The more negative take on it is all of these drugs showed the exact same effect, about 25 or 30%. And is that the ceiling even for the prevention studies too?
Yeah.
All right. Anyway,
Cool.
great job, Daniel.
Thank you. So,
Well done.
oh, thanks.